Clinical chemistry, electrolytes. Electrolytes are ions that are capable of carrying an electric charge. There's two types, anions and cations. Anions have a negative charge and cations have a positive charge. The way that I keep this different in my mind and the way that I remember it is I like cats. I'm an animal lover and I like cats. So cats make me happy, cats positive. Cations have a positive charge. Anions, if you think of like anarchy, that's probably not a good thing. So that's just how I remember. Anions are negative. Electrolytes are an essential component in many processes. They play a role in volume and osmotic regulation, or water homeostasis. So potassium, or sodium chloride, and potassium are major players there. Myocardial rhythm and contractility of not only heart muscle, but also just muscle in general, skeletal muscle and smooth muscle, potassium, magnesium, and calcium. Cofactors in enzyme activation, magnesium, calcium, and zinc. Blood coagulation, calcium and magnesium, and the maintenance of pH, bicarbonate. This is not an all-inclusive list, but when you take a look at these element symbols, you should definitely know their name associated with the symbol. So by now, you should know that Na is sodium and K is potassium. If you don't, you should really take some time to review these and know these for sure. Not only for this class and for tests that come up, but also in your futures, because you're going to be seeing these things and they may just give you the symbol and you need to know the name. So be familiar with those. Intracellular and extracellular fluid has some different compositions. So intracellular fluid, intra means inside of, cellular is talking about the cells. So we're talking about the fluid inside of the cell. Extra means outside of. Cellular, again, we're talking about the fluid outside of the cell. So intracellular is inside of the cell, extracellular is outside of the cell. There's a different composition of these fluids. Overall, the charge inside is a bit more negative than the outside, but you can see that we do have some balance with the cations and anions both inside and outside of the cell. So in extracellular fluid, I have kind of highlighted the ones that are important to know that have higher concentrations. So outside of the cell, we see higher concentrations of sodium, chloride, and bicarbonate. While inside of the cell, we see higher concentrations of potassium, phosphates, and protein. So what produces the overall positive charge outside of the cell would be the predominantly the sodium, and the negative charge outside of the cell is the chloride and bicarbonate. While inside of the cell, the positive charge is regulated by that potassium concentration, and the negative charge is regulated by the phosphates and these proteins, which have a negative charge. Water is 40 to 75% of the human body weight. It declines with age and obesity, and it's less in women than in men due to the higher percentage of body fat. Water is a solvent for all processes in the human body, so it plays a role in transporting nutrients to cells. It determines cell volumes by its transport into and out of cells. It removes waste products in the form of urine and acts as body's coolant in the form of sweating. It's found in intracellular and extracellular compartments. So intracellular fluid is about 2/3 of the body fluid, so about 66% of the water is an intracellular fluid. And extracellular fluid is about 1/3 of the total body water. Osmolality is a physical property of a solution based on the concentration of solutes in millimoles per kilogram of solvent. It's related to changes in properties of solution relative to pure water, so decreases in freezing point and vapor pressure. Clinical significance of osmolality. Osmolality is a parameter to which the hypothalamus responds. Regulation of osmolality affects plasma sodium concentration, and regulation of sodium in water controls blood volume. The determination of osmolality, so it may be measured in serum or urine clinically. This is a diagram that I'd like you to review that talks about responses to changes in blood osmolality and blood volume. If you have hyperosmolality, hyper means too high, osmolality, we're talking about that concentration relative to water, so we have too much solute. Typically, that the side effect of having that would be thirst. Hypernatremia is also another cause of this, but this is going to signal to the hypothalamus to produce antidiuretic hormone, which is then going to be released from the posterior pituitary. Antidiuretic hormone. Anti means against. Diuretic is talking about the loss of water. So the antidiuretic hormone is against diuresis. In other words, it's going to cause water retention in the body. So water is going to be retained. ADH is going to directly cause the reabsorption of water from the kidney tubules. Another instance would be hypovolemia. Hypo means not enough. Volemia is referring to blood volume. So if we have a dip in blood volume, this is also going to act as a mechanism that's going to trigger the ADH response. So if we have low blood volume, that typically can be corrected by adding more water to it. So if that would bring more water into the body, we would increase our blood volume back to normal. And we can do that using that antidiuretic hormone. Hypervolemia means too much blood volume. That's going to put pressure and strain on the heart to pump that increased blood pressure throughout the body. That's sensed by the atria of the heart. So there's receptors in there that can sense that, and they're going to release atrial natriuretic peptide, ANP. And ANP is going to do the opposite of ADH. ANP is going to lead to water excretion and also vasodilation to kind of decrease the blood pressure. If we dilate the blood vessels, if we increase the volume inside of the blood vessels, it's going to be less pressurized. And then we can see the angiotensin-aldosterone, or renin-angiotensin-aldosterone system down here. So this is a review of what was discussed previously in the class. So now we're going to go through each electrolyte. We're going to talk about some imbalances with the electrolytes, and then we'll end our discussion by talking about just some general specimen collection stuff and go through things that can happen during analysis in the clinical lab. Starting with sodium. So sodium is the most abundant cation in extracellular fluid. So that table that I showed you, that diagram I showed you earlier, you can see that sodium is the predominant cation in the extracellular fluid. This largely determines the osmolality of the plasma. If we have a high sodium concentration, we have a higher osmolality. If we have a lower sodium concentration, we have a lower osmolality. Sodium concentration in the extracellular fluid is much larger than in the intracellular fluid. Active transport systems, such as ATPase, ion pumps, sodium-potassium pumps, prevent sodium equilibrium in all cells. Regulation, the intake of water in response to thirst, excretion of water, and blood volume status. Sodium imbalance, so hyponatremia. This is where it's going to be important to break down all of these words into their stems and try to pick apart what these stems mean. Hypo means not enough. Na is the element symbol for sodium. So in this case, hyponatremia means we have decreased plasma sodium concentrations. When we say decreased plasma sodium, we're referring to less than 136 millimoles per liter. It's clinically manifested as weakness, mental confusion, and then severe mental impairment at really low levels. The central nervous system symptoms are due to intracellular shifting of water to maintain the osmotic balance, and that results in swelling of the central nervous system cells. So if you don't have enough sodium outside of the cells, water is going to want to rush into the cells to dilute out the concentrations and keep the concentrations inside and outside of the cells the same. So when water rushes in, we have swelling of the central nervous system cells. It may occur in conditions of hyperosmotic, isoosmotic, or hypo-osmotic plasma, and we will discuss each one of these individually as we go through the next few slides. Assessment of plasma osmolality is important to identify the cause, and the most common one is a hypoosmotic state. So hyperosmotic hyponatremia. An increase in extracellular fluid solutes results in a shift of extracellular water or intracellular sodium to maintain the osmotic balance. Severe hyperglycemia. Iso-osmotic or pseudo-hyponatremia, which is caused by an electron exclusion effect. Electrons are excluded from the fraction of total plasma volume occupied by the solids. It leads to an underestimation of the electrolyte concentration by some methods. The flame emission spectrophotometry, ion selective electrode methods are typically the ones that are affected. This is seen with hyperlipidemia and hyperproteinemia. So hyperlipidemia, too much lipids, hyperproteinemia, too much protein. Hypo-osmotic hyponatremia is caused by an excess loss of sodium or increased extracellular volume. Differentiation requires clinical assessment of total body water, TBW, and extracellular fluid volume. Depletion hyponatremia is due to the excessive loss of sodium. It almost always occurs with the loss of extracellular fluid water. Hypovolemia is evident as tachycardia, decreased skin turgor. Loss through renal or extrarenal routes. Dilutional hyponatremia is a result of excess water retention. It may be noted as weight gain or edema. Increased extracellular fluid, decreased blood volume. Congestive heart failure, hepatic cirrhosis, or nephrotic syndrome. Hyponatremia versus volume status. Hypovolemic, the sodium loss is due to excess water loss. Thiazide diuretics, loss of hypertonic fluids through burns or sweating, or potassium depletion. Euvolemic, there's a problem with water balance, an inappropriate ADH secretion, artificial due to hyperlipidemia, or hyperosmolar from other substances, or adrenal insufficiency. Hypervolemic, excess water retention, the movement of fluid intravascular space to interstitial space. Advanced renal failure with excess water intake, congestive heart failure, cirrhosis, and nephrotic syndrome. So when we talk about these hypovolemic, euvolemic, and hypervolemic, hypovolemic means not enough blood volume. Euvolemic is the blood volume is at appropriate level. Hypervolemic means that there's too much blood volume. So those were hyponatremias, not enough sodium. Now we're going to switch gears and talk about hypernatremia, too much sodium. So we have an increased plasma sodium that's greater than 150 millimoles per liter. Symptoms are primarily neurologic. That's due to intracellular dehydration. It causes tremors, irritability, ataxia, confusion, and coma. So when you have a lot of solute in the extracellular environment, the water is going to want to rush out to dilute that away. So water is going to want to go to the area where you have higher solute concentration. So if you have a ton of sodium outside the cells, water is going to leave the cells in order to dilute out that external environment. This is something that you can see when we put salt on the ground during wintertime. The salt is designed to decrease the melting point of the ice so that we can melt that ice on the sidewalks. But once we have everything kind of go back to normal and things are melting and we have that water from that salt or the water mixed with that salt, we have now created a hypertonic environment around plants. So what happens when plants are near that salt water is the plants are going to lose water to their external environment because water is going to want to rush out of the plants to dilute out the environment. Same thing's going to happen here. So if we have too much sodium outside of our cells, water is going to rush out and that causes intracellular dehydration. It typically occurs in those with normal thirst response, but inability to hydrate themselves. It arises from excessive water loss or failure to replace normal water loss, a net gain of sodium in excess water, decreased sodium excretion, and the diagnosis depends on the assessment of total body water, urine sodium, and urine osmolality. There is hypovolemic and hypervolemic. So hypovolemic is abnormal decrease in plasma volume. It's caused by renal or extrarenal loss of hypo-osmotic fluid. Extrarenal loss, concentrated urine with low urine sodium. Diarrhea, skin losses, respiratory losses, coupled with failure to replace lost water. Renal loss, osmotic diuresis, thiazide diuretics. Urine volume is high, urine osmolality is low and urine sodium is high. Hypervolemic, you have excess total body water with excess sodium. Indicates net gain of water and sodium. Sodium is in excess of water. Common in hospitalized patients receiving hypertonic, saline, or sodium bicarbonate. It's also seen in hyperaldosteronism or Cushing syndrome. So now we're going to switch gears to potassium. Remember, potassium element symbol is K. The major intracellular cation in the body. Intracellular, we're talking about inside of the body. Cation means it has a positive charge. Intracellular is inside of the cell. Cation, we're talking about a positive charge. So positively charged ion inside of the cell. Concentration is 20 times greater inside the cells than outside the cells. Functions include the following. So regulation of neuromuscular excitability, contraction of heart, intracellular fluid volume, and hydrogen ion concentration. So when we have any type of muscle contraction, including the heart muscle contraction, the nerve impulse, anything like that, we have a movement of ions from the inside to the outside and outside to the inside. So in our nerve impulse, we have sodium rush into the cells, and then potassium rushes out of the cells. And then more potassium will rush out of the cells, and then we have this whole system reset for each nerve impulse. So anytime we have that neuromuscular excitability, we need to have both sodium and potassium present. The kidneys regulate potassium balance. Potassium uptake from extracellular fluid goes into the cells and normalizes the acute risk in plasma potassium concentration due to increased intake. Factors that influence distribution of potassium: the inhibition of the sodium-potassium pump by certain conditions. Insulin promotes potassium ions entering muscle and liver, and catecholamines promote cellular entry of potassium. Exercise increases plasma potassium. Hyperosmolality depletes potassium. Cellular breakdown releases potassium into the extracellular fluid. So if we have cells that are breaking open, anything that's predominantly inside of the cell is now going to be outside of the cell. So if we have cells that are breaking open, we can see an increase in extracellular potassium. Clinical applications: hypokalemia, lower than normal plasma potassium, and hyperkalemia, higher than normal plasma potassium. Something that's very important to note is with potassium, hemolysis absolutely has to be avoided. So if we see hemolysis in the blood sample, we cannot trust our potassium values. Why do you think that is? Well, if we have hemolysis, hemolysis, we're talking about the rupture of red blood cells. Those blood cells are going to break open and release that hemoglobin, which is going to cause pigmentation of the serum or plasma, whatever we're measuring. But also, anything that was supposed to be inside of the cell is also going to rush out, so including potassium. So if we all of a sudden see a sharp elevation in potassium levels and we notice that there is hemolysis, that's probably why. Hypokalemia is plasma potassium less than 3.5 millimoles per liter. It leads to muscle weakness, paralysis, disrupt biochemical and structural integrity of muscle cells, tachycardia, cardiac arrhythmias, and cardiac arrest. It leads to alkalemia due to redistribution of hydrogen ions to the intracellular fluid for activating the sodium-potassium pump. Redistribution hypokalemia, the initiation of insulin therapy, or alkalosis pseudohypokalemia, is time-dependent transport of potassium into leukemic cells after the sample is drawn. True hypokalemia, 24-hour urine potassium, either renal or non-renal losses, less than 25 to 30 millimoles per day. The kidneys are functioning properly and attempting to absorb as much sodium as possible, or potassium as possible, but the losses are due to decreased potassium intake, so chronic starvation or extrarenal loss, diarrhea or vomiting. If we have greater than 25 to 30 millimoles per day, it indicates the kidneys are the primary source of this potassium loss. It may occur with recovery, diuretic phase of acute tubular necrosis, with primary or secondary aldosteronism. Excess mineralocorticoids can cause this, or Cushing's syndrome, excess glucocorticoids. Hyperkalemia is too much potassium, so plasma potassium levels are greater than 5 millimoles per liter. It leads to muscle weakness, bradycardia, or slowed heart rate, and leads to acidemia due to redistribution of hydrogen ions. Redistribution of intracellular potassium to the extracellular fluid occurs with acidosis. Potassium will rise 0.2 to 0.7 millimoles per liter for every 0.1 unit drop in pH. Also occurs with dehydration, shock, tissue hypoxia, severe burns, violent muscle activity associated with seizures. Letadogenic causes, that term just means causes that are related to a treatment from a healthcare professional. We have digoxin toxicity and beta-adrenergic blockade. So these are medications that can lead to this. Excuse me. Hyperkalemia, potassium retention, it's observed with acute renal disease, end-stage renal failure, shock-induced renal failure, renal tubular acidosis, and we have interference with sodium and hydrogen exchange in the tubules, which leads to potassium retention. It occurs with sodium depletion, with adrenocortical insufficiency, Addison's disease, diminished sodium reabsorption with concomitant decrease in sodium-potassium exchange results in decreased potassium secretion. Drug-induced, drugs that block the production of aldosterone. In the absence of severe renal failure, hyperkalemia is rarely prolonged. Switching gears to chloride. So chloride is the major extracellular anion. So that means it has a negative charge. Functions, it maintains the osmolality, blood volume, electric neutrality. So it kind of counters sodium in the extracellular environment. It's ingested in the diet and almost completely absorbed by the intestinal tract. The chloride shift is talking about bicarbonate leaving the cells and chloride entering the cells. So that's something that we will talk a little bit more in detail once we get to the acid-base balance of the body. Clinical applications, hyperchloremia is talking about too much chloride. Hypochloremia is talking about not enough chloride. It's important to talk about the name chloride just for a second. Chloride is the element chlorine in ion form. So when we have negatively charged, they end up losing electrons, they end up gaining electrons, and they get that IDE ending when we talk about them in their ionic form. So chlorine as an element is different from chloride as an ion. So chloride has that full 8 outer shell of electrons, and it's going to have gained 1 electron, so it gains 1 negative charge. So that becomes Cl minus 1 or just Cl minus. So that's just one distinction between chloride and chlorine. Determinations of chloride, the specimen, serum, plasma, urine, sweat. The method is ISE, ion-specific electrophoresis. So we have hypochloremia, observed in patients with salt-losing nephritis in the presence of hyponatremia. Pyelonephritis, the loss is likely due to defective tubular reabsorption. It's often associated with an acid-base disturbance. With metabolic acidosis, it's caused by increased production or decreased excretion of organic acids. Diabetic ketoacidosis or renal failure. Compensated respiratory acidosis, metabolic alkalosis due to increased bicarbonate. So we will be talking about compensated versus non-compensated or uncompensated respiratory and metabolic alkalosis and acidosis once we get to acid-base balance of the body. Persistent gastric secretion and prolonged vomiting. Hyperchloremia is associated with bicarbonate loss, so renal tubular acidosis, acute renal failure, metabolic acidosis associated with prolonged diarrhea, or GI disturbances. Dehydration, adrenocortical hyperfunction, and diabetes insipidus. Compensated respiratory alkalosis often accompanies hypernatremia. Hyperchloremic acidosis may be a sign of severe renal tubular disease. It's also seen with diets extremely high in salt and overtreatment with saline solutions. Cystic fibrosis has been mentioned previously in this class, just briefly, but it is the most common lethal genetic disorder in the Caucasian population. It's due to a defect in the cystic fibrosis transmembrane conductance regulator protein, or CFTR. Normally regulates electrolyte transport across the epithelial membranes, but mutations prevent the transport of sodium and chloride into the mucus producing epithelial cells. This results in thick mucus production in the lungs. Symptoms include chronic or recurrent respiratory infections, pancreatic exocrine dysfunction, endocrine dysfunction, and meconium ileus in the newborn. The sweat test is depicted here. So pre-weighed gauze pads or filter paper minimize evaporation and contamination. The analysis of sweat chloride, sodium, conductivity, or osmolality. Chloride provides a better diagnostics discrimination. If it's greater than 60 millimoles per liter, it's consistent with cystic fibrosis. If it's less than 40, it's considered normal. So special sample considerations. Sodium and chloride are not affected by hemolysis. Sodium lipemic samples should be cleared if analyzed by ion-specific electrode. Chloride is very stable, and it's not typically impacted by lipemic samples. Potassium, though, is a little tricky. Like I mentioned earlier, we have to watch hemolysis. Levels in the plasma whole blood are 0.1 to 0.7 millimoles per liter lower than in serum, and it's also dependent on platelet count. So if we have active cells, those cells are going to be taking up potassium from the environment, so that can decrease our potassium levels. You want to minimize hemolysis, so it increases 0.6% potassium for every 10 milligrams per deciliter of hemoglobin. The process samples quickly, so falsely elevated if it's stored at 4 degrees Celsius, falsely decreased if it's stored at 37 degrees because of leukocytosis present. It can be elevated by the use of a tourniquet, especially if the patient pumps the fist repeatedly. Reference levels are listed in this table. And then the analysis of electrolytes. The ion-selective electrodes are the most common. It's measured in serum plasma or urine. Heparinized plasma, capillary blood, or a finger stick is also acceptable. Heparinized arterial specimens collected for blood gases may also be used. Urine collection, timed collections are preferable. No addition of preservatives. Occasionally in feces or GI fluid. It requires the sample preparation before analysis. Clear of particulate matter prior to analysis, and requires cleaning of instruments after analysis. Typically performed only on liquid fecal samples, and it signifies significant loss of electrolytes. So switching gears to talk a little bit about bicarbonate. So bicarbonate is HCO3-. It's the second most abundant anion in extracellular fluid. The main buffering component of the blood, produced from carbon dioxide by carbonic anhydrase or carbonic acid in red blood cells. So here, carbonic anhydrase is the enzyme that produces it from carbonic acid. So here you can see we have carbon dioxide combined with water, and then we have this enzyme that turns it into carbonic acid, and the enzyme then turns it into hydrogen ions and bicarbonate. And this will be discussed in a little bit more detail once we get to the acid-base balance of the body. But this is basically our respiratory kind of buffering system here. So it buffers against acidosis by combining with excess hydrogens to produce carbon dioxide and water. It is eliminated in the lungs as carbon dioxide. It diffuses out of the cells in exchange for chloride to maintain electric neutrality. So that's where we have the chloride shift. So chloride goes in, bicarbonate comes out. Total carbon dioxide of plasma, carbon dioxide in aqueous solutions, carbon dioxide bound to proteins, and bicarbonate and carbonic acid. It's greater than 90% is bicarbonate at physiological pH. Normal level is 22 to 31 millimoles per liter. All but about 2 millimoles per liter is bicarbonate. Alterations of bicarbonate and carbon dioxide dissolved in plasma are characteristic of acid-base imbalances. Most value in the context of other electrolytes with blood gases and pH values. We will be talking about blood gases in the next lecture. Bicarbonate regulation, it's reabsorbed in the kidney as carbon dioxide, about 85% in the proximal tubule and 15% in the distal tubule. In the tubule, it's then converted, carbon dioxide diffuses back into extracellular fluid. In alkalosis, where the blood pH is too high, we have a relative increase in bicarbonate compared to carbon dioxide. Excess bicarbonate is excreted with the cation sodium, and loss of bicarbonate from the body helps to correct the pH. In acidosis, where the pH is too low, increased hydrogen is excreted in the urine, and virtually all bicarbonate is reabsorbed. Bicarbonate analysis, venous serum, heparinized plasma, protect from the atmosphere because it's going to lose carbon dioxide. Analyze immediately upon separating serum from plasma from red blood cells. Ion-specific electrode, the indirect method, acid reagent to convert all forms of carbon dioxide to carbon dioxide gas. The gas diffuses across a silicone membrane into an alkaline reagent. Change in pH is measured by an electrode, and it's proportional to the amount of carbon dioxide gas present. Total carbon dioxide is calculated based on the difference with the reference electrode. Bicarbonate excretion, it's excreted when blood levels are greater than 26 to 30 millimoles per liter. Plasma levels will be greater than 30 millimoles per liter only if bicarbonate capabilities fail. Increased bicarbonate via infusion of lactate, acetate, or bicarbonate by IV. Excessive loss of chloride without replacement. Bicarbonate is retained to maintain the electric neutrality, so to kind of balance out that sodium. Decreased bicarbonate. Diuretics favor excretion of bicarbonate. Conditions with excessive loss of cations. Kidney dysfunction with impaired reabsorption. Chronic nephritis and infection. Then we have the anion gap. The anion gap is an important measure for clinical chemistry, and it's typically reported in all clinical chemistry panels that are relevant to electrolytes. The difference in concentration of the cations and the anions commonly measured in chemistry test panel. It's calculated using the measured sodium, chloride, and bicarbonate, and sometimes potassium. So here you can see the two equations. If we include potassium, we have a normal range of 11 to 20. And if we do not include potassium, we have a normal range of 8 to 16. Means to estimate abnormally high concentrations of one or more unmeasured anions. Elevated anion gap indicates that there's an elevation of lactate, keto acids, or anionic metabolite of a toxin or drug. So here you can see what would be a normal acid-base status, and if we have an increased anion gap, so a high anion gap, that can indicate acidosis, so ketoacidosis or starvation. And if we have a non-anion gap, then that's typically due to fluid loss or renal tubular acidosis. So knowing information about that anion gap can give us an idea of the health status of the patient. So there's just a few more electrolytes to wrap up the lecture for this series. So magnesium, it's the fourth most abundant cation in the body and second intracellularly. Average human body contains 1 mole or 25 grams of magnesium. It's widespread role in the body: glycolysis, transcellular ion transport, neuromuscular transmission, synthesis of carbohydrates, proteins, lipids, nucleic acids, the release of and response to certain hormones. Rich sources of magnesium include raw nuts, dry cereal, hard drinking water, vegetables, meats, fish, and fruit. Consumption of processed foods can lead to inadequate intake. Regulation of body magnesium controlled largely by kidneys, which can reabsorb it in deficient states or excrete excess. Hypomagnesemia and hypermagnesemia. I'm sure you can already define these by now. So hypomagnesemia is talking about not enough magnesium. Hyper is talking about too much. In order to evaluate levels, we need a non-hemolyzed serum or lithium heparin plasma. Methods: Calmagite, formazan dye, or methylthymal blue. Calcium is essential for myocardial contraction. Also, just regular skeletal muscle contraction. It's essential for a lot of different processes in the body. It's 99% of calcium in the body is part of bone, and remaining 1% is mostly in the blood and other extracellular fluid. As little is in the cytosol of most cells. Blood ionized calcium is closely regulated and has mean concentration in humans of about 1.18 millimoles per liter. It's important to maintain normal ionized levels during surgery and critically ill patients. Regulation is dependent on three main hormones: parathyroid hormone, vitamin D, and calcitonin. So parathyroid hormone would increase blood calcium, calcitonin would decrease blood calcium, along with vitamin D would decrease blood calcium. Calcium distribution: 99% of the body calcium is in bone, as mentioned previously, 1% is in blood. Of the total amount that's in blood, 45% circulates at free calcium ions, 40% is bound to protein, and 15% is bound to anions. Clinical applications: hypocalcemia, not enough calcium; hyperkalemia, too much calcium. The determination of calcium can be done in serum plasma, and the methods include dye binding. Phosphate is found everywhere in living cells. It participates in key chemical processes, may be absorbed in the intestine from dietary sources. It's released from cells into the blood and lost from bone. Distribution: 80% is in bone, 20% in soft tissues, less than 1% is in serum or plasma. Hypophosphatemia and hyperphosphatemia. Hypo is too little, hyper is too much. Specimens include serum, lithium heparin plasma, and the methods include formation of an ammonium phosphomolybdate complex. Lactate is a byproduct of an emergency mechanism that produces a small amount of ATP when oxygen is severely diminished. It's not specifically regulated, but levels rise rapidly when oxygen delivery decreases below a critical level. Clinical applications include metabolic monitoring in critically ill patients. Specimen handling: you want to avoid using a tourniquet. If a tourniquet is used, blood should be collected immediately, and the patient should not exercise the hand before or during collection. Methods most commonly today are enzymatic methods. So this is a summary of the electrolyte excretion and conservation. The glomerulus filters out the large proteins and protein-bound particles. And then we have the renal tubules, where we have the reabsorption of some of these major ions. So phosphate is reabsorbed. The reabsorption is inhibited by parathyroid hormone. Same thing with calcium. Calcium reabsorption is under the influence of parathyroid hormone. Magnesium reabsorption occurs in Henle's loop. Sodium reabsorption occurs through three different mechanisms. Chloride reabsorption is by passive transport in the proximal tubule. Potassium is reabsorbed by two mechanisms. Bicarbonate is recovered from the glomerular filtrate.